Hello, my name is Alex Arroyo. I am at the Maimonides Medical Center, and I will be lecturing about the ultrasound of pyloric stenosis. So let's start with the case. It's 12 a.m. A 3-week-old firstborn male presents with 4 days of progressive non-bilious vomiting and slightly decreased urine output. Saw the PMD at the onset of the illness, and today has had a documented 4-ounce weight loss. On exam, the baby is hungry, slightly pale, but interactive. What to do at 12 a.m.? Obviously, we're on the case of pyloric stenosis at this point, and our options are as follows. You could place an IV, hydrate the child, and wait 9 hours for the radiology tech or the radiology technician to arrive to perform the ultrasound, because in most places, the residents are not very comfortable doing pyloric ultrasounds. You could place an IV, hydrate, and PO challenge. If the baby tolerates PO, you could discharge them. Symptoms persist, you could tell them to come back in the AM for an ultrasound. Or if the vomiting persists while you're hydrating them, you can admit them for a sonogram. Or you could take this, bring it to this, place it on one of these, and come up with this. Indications for a pyloric ultrasound. Average age of the diagnosis of pyloric in children is about 3 weeks. The range is about 1 to 18 weeks. It's non-bilious vomiting for the most part, not always, but for the most part non-bilious vomiting. 70% of it is usually projectile. It may be intermittent, or it may happen with each feed. It usually becomes progressive as the muscle hypertrophies, and the baby is usually hungry after vomiting. You may see signs of dehydration and malnutrition if it's been going on long enough. There may be poor weight gain, weight loss, decreased urinary output, and classically, if it's been going on for a long time, you may see the signs of hypokalemic metabolic alkalosis. Your probe selection, you want to use the linear probe. You can put it in small parts mode, superficial or musculoskeletal settings. There may be a pediatric abdominal mode on your machine. Linear probe is used because we want the maximum resolution and not penetration, because the pylorus just lies literally centimeters below the surface of the skin on most infants. Your technique, you want to feed the baby when you're scanning. We'll talk about that in a second. You also want to place the child in right lateral decubitus position. This is going to allow fluid in the stomach to distend the antrum and the pyloric region, pulling it down so it's a little easier to actually visualize. Also attempting to soothe the infant while you're doing the exam, because usually they're crying and swallowing a large amount of gas, which is going to increase your amount of bowel gas that you have there, and then prevent the ultrasound beam from penetrating to the structures you're looking for. You want to use graded compression to push away the bowel gas. Make sure you slide it to the side so you could actually see the pylorus and see the stomach. You want to use the stomach and the liver and the gallbladder as landmarks. Usually the pylorus sits somewhere within that area, in between the stomach and the liver and the gallbladder, just below the gallbladder usually. You want to start at the stomach and look for fluid entering. This is why we feed the baby during the examination, because as the stomach gets distended with the fluid of the milk or the Pedialyte you're feeding the baby, it starts to distend the stomach and then open up the entrance to the pylorus. And we're also using the fluid in the stomach as a medium to propagate the sound waves from the ultrasound beam. You want to trace the stomach to its end, which is going to be near the midline of the patient, just below the sternum usually, and the pylorus should come into view as the stomach distends. Also, frequently, if I see a pyloric stenosis, I'm going to do a renal sonogram, because there's been a high incidence of renal abnormalities with pyloric stenosis, like a UPJ obstruction, renal agenesis, or maybe even a horseshoe kidney. Here's a diagram of the pylorus in relation to the stomach, liver, and the gallbladder. As you can see, the pylorus is at the exit of the stomach, just below the gallbladder and or liver. For the most part, you usually find it within that triangle that the gallbladder, liver, and stomach make. When you're scanning the pylorus, the orientation that you'll see on the longitudinal view when you're at the pylorus will appear like this. So here's your ultrasound probe with the beam coming through, getting a longitudinal image of the pylorus. And in transition, what you'll see on the screen is this. Stomach is to the right, and we can see the pylorus right there. We can see the contents entering the pylorus and exiting the back. Video flips, again you'll see it. And this is the longitudinal view of the pylorus. The specific structures we see here are going to be, the two blue arrows represent the hypoechoic muscular layer of the pylorus, which is what thickens during pyloric stenosis. And you can measure them across like that. And then you'll see this alternating hyperechoic, hypoechoic structure in between the muscle layer, which is going to be the hyperechoic pyloric canal or the channel. We could also measure that as well, which we'll talk about very shortly. When you're scanning the pylorus in the transverse view, your beam will come through like this, and you'll get images on the screen that correspond to this, the transverse view of the pylorus. In transverse view, the pylorus actually looks like a target sign if it's thickened, with the canal or the channel in the middle and the wall on the outside. Here we see the video going into the stomach and back into the canal. It's a detailed view of a still shot of the pylorus. The yellow layer in the middle is the canal or the channel, and the outer layer right here, measured from any one of the distances from the canal to the outside of the muscle layer, is going to be the muscle. So sonography is said to have a sensitivity of about 90 to 96% on studies. Pretty good, not perfect, but for our purposes is actually very, very good. Muscle wall thickness, anywhere between greater than 3 to 3.5 millimeters, depending on who you read. And the canal or the channel length, anything greater than 1.2 to 1.7 centimeters. I usually err on the side of the lower numbers, and then discuss with surgery and go from there, depending on what they want to do. There's usually no peristalsis of the pylorus. You won't see it actually moving when the baby's being fed. And there's no or little movement of stomach contents to the duodenum. The pyloric stenosis is a progressive disease, so as the muscle thickens, eventually it's going to completely close off. So at some point, even if it's not 100% closed off, you still may see some movements of stomach contents into the duodenum. Here's a still shot of a normal pylorus. You can see the stomach directly in the middle of the screen right here. The liver is on the left side over here, and the pylorus is noted by the arrow. You can almost see the lips of the pylorus coming out through the right at the port where the pylorus meets the stomach. Here's another shot of a normal pylorus. The muscular layer is detailed by the blue hash marks down at the bottom. It's only 0.24 centimeters. So this is a negative study, and you can see how close to the liver it actually sits. Normal pyloric muscle. Here's a still shot of an abnormal pylorus. It's thickened. The blue hash marks are 0.56 centimeters. That's the thickness of the muscle from the canal down to the end of the muscular wall. Either side would measure just about the same. The hash marks of the white stars in the middle represent the pyloric canal, and that's 1.9 centimeters if measured from end to end. Here's a video measuring the canal. It starts from the onset of the stomach on the left-hand side there. This video is actually flipped, so the stomach's on the left, and then continues to the back of the pyloric muscle, and that's 2.37 centimeters, well above normal. Here's a transverse shot of the pylorus. The canal is being measured from, the muscle is being measured from the canal to the upper muscular wall. It is 0.49 centimeters. The stomach is just above. In this view, the transverse view, you cannot measure the canal because you're seeing it head on and not longitudinally. And it looks like a target, some have said, on the transverse view. Here's a video measuring the muscular wall from the canal to the end of the muscle. You can measure it from the upper aspect, from the lateral aspect. Pretty much anywhere should be about the same. These are 0.51 and 0.54 centimeters respectively. Well above normal. Here's a video looking at the pylorus on transverse right now. You can see it in the middle of the screen. This video is also flipped. The liver is on the right side. It should be on the left side. And we'll see the stomach come into play on the left side as well. So again, you're getting some gas there. We're just pushing it away with graded compression. You get the pylorus right there. Now we're going to transition from the transverse to the longitudinal view, and you can see the stomach on the left-hand side there. Remember, the video is flipped, and you can see clearly the canal right in the center of the screen. And as you notice, if you look at the hash marks on the side of the screen, the pylorus is literally about 3/4 of a centimeter below the surface of the skin. So this is why, again, we use the linear probe and not the abdominal probe, because we're looking for our resolution, not penetration. And here I'm measuring both sides of the wall, upper and lower portion, from the canal up to the upper portion of the wall. So pyloric stenosis pearls. Once again, you want to have a full stomach when you're actually ultrasounding. You want to feed the baby while you're scanning, because this is going to distend the stomach. It's going to open up the pylorus for you, so you could trace the stomach right into the pylorus, and also make the baby a little more calm when you're actually doing it, so they're not screaming and swallowing air and preventing the beams from seeing the pylorus. You want to use graded compression. Push down on those gas pockets. Push the gas away. This is when the baby starts to get cranky a little bit. So again, feeding the baby while scanning may help. Soothing the baby may help. You want to put the child in right lateral decubitus position. Pull that pylorus down. Pull the stomach down so you could actually see it a little bit better. It should sit on the midline when you actually have them in this position. And you want to use the liver, stomach, and the gallbladder as landmarks. Pylorus is going to sit somewhere in that triangle of the liver, stomach, and gallbladder when you actually look for it. Some pitfalls. You can get a false positive from pseudo-thickening of the pyloric muscle. And this is going to happen if you're tangential, which is basically off the midline orientation. If you're catching it not exactly 100% longitudinal or not exactly 100% transverse. If you measure the muscle tangentially, it'll appear thicker than it actually is. And if you have gastric decompression, if there's nothing in the stomach, the baby just vomited, the pylorus is gonna shrink but thicken the walls from the sides, and you actually, when you measure it from there, you may get a positive. But the pylorus is so small, it looks like it's actually thickened when it's really not. False negatives you get from usually non-visualization of the pylorus, and this is when it's posteriorly displaced. And you may get that from gastric overdistension. And that's if you feed the baby too much. So this is why we recommend feeding the baby while you're scanning, so you can get to the exact point where you see the pylorus very nicely, and then pull the bottle out and then start scanning. Because if it's overdistended, it's going to push the pylorus posteriorly and you won't be able to see it. Here's a little algorithm to deal with the vomiting infant and how ultrasound plays into the diagnosis of pyloric stenosis in the emergency department. So on the top, you have a vomiting infant. If it's bilious, it's usually not pyloric stenosis for the most part. Those patients are usually going to be sick. You want IV fluids and labs on them. They're going to have things like intestinal atresia, malrotation with volvulus usually, and they need a different ultrasound, study than ultrasound, usually a upper GI barium swallow. If it is non-bilious vomiting and the patient looks well hydrated in the middle of the algorithm, they tolerate PO, they could probably be discharged home safely with obvious good discharge instructions to return if the vomiting persists. If they are dehydrated, they need IV fluids and labs first and foremost. And usually if they tolerate PO, likely a gastroenteritis, DC, again with good discharge instructions. If the patient fails PO challenge, bedside ultrasound is indicated. If that bedside ultrasound is negative, you visualize the pylorus, you get measurements below 3, below 1.2, likely gastroenteritis. Child may need to be admitted for IV fluids and hydration. If that bedside ultrasound is positive, your diagnosis of pyloric stenosis is pretty concrete. You want to discuss with surgery. Admit the child plus or minus a diagnostic ultrasound by the radiology department. Here are the references for the lecture. I'd like to thank Dr. Herbst and my mentor, Dr.